we have seen so many women chatting in our various communities. They are chatting. They are 7 cm dilated. They are 8 cm dilated. It's paining me. It's paining me. What should I do? It's like, push. This nurse is not answering me. Tell your husband to call her. Tell your husband to call her. He said, hey. He said, yes. But I'm not feeling the contractions again. Get up. Oh, but the nurse is telling me to lie down. Go to the toilet.
Hello there. You're welcome to our Health Hour, your go-to podcast for informative discussions around women's health. In the gym, your car, kitchen, or wherever you decide, tune in every 2 weeks for new hot topics you don't want to miss. And hold on, do not forget to follow us on all our social media platforms so you join the conversations at our Health Hour.
Hello everyone, you're welcome to another episode of our Health Hour. This is your go-to podcast for everything related to women's health. And today with me in the studio is Hikmat, and we have a special guest with us, a very beautiful, knowledgeable, humble medical doctor, the founder and CEO of Birthsafe Nigeria, Dr. Idara Umoette. Dr. Idara is changing the narrative of maternal health mortality in Nigeria, and she is also leading that with an innovative solution, an innovative platform called Birthsafe Nigeria. I'm going to hand over now to Dr. Idara to introduce herself and walk us through our journey as a medical doctor and as a founder of Birthsafe Nigeria. Over to you, Dr. Idara. We're so pleased to have you with us, by the way.
Thank you so much. The pleasure is mine. Hello, everyone. Hello, viewers, listeners. Hello, everyone. So my name is Dr. Idara Umoette. I am a medical doctor of over 18 years experience. Time flies too fast. And the founder of Birthsafe Nigeria, which is a digital antenatal service provider. And all of this English is to say that the platform digitally delivers antenatal solutions to women, especially of color, so that they avoid complications. They don't run into complications in pregnancy and childbirth. So I've been doing this medicine thing for, as you have heard, quite a bit. I'm passionate about all things humanity and all things female because I have very, very strong convictions. Like my inner tiger, my inner dragon comes out when it has to do with anything women and anything children, because I see that they are unable to speak up as much for themselves. I see that there's a lot of inequalities in care. So, because I see that for especially women of color, because of socioeconomic reasons, the quality of care that they receive, there's a lot of dismissal. There's a lot of playing down around the kind of help that they receive. And for these reasons, our numbers are really bad globally. I mean, we've had figures like Serena Williams come out and shout and cry about the lower quality of care, or the lower standard of care that Black women receive, especially when they are pregnant. And this has largely contributed to the high numbers, to the almost criminal numbers of maternal mortality that we see. A Black woman is 3 to 4 times more likely to lose her life in the course of pregnancy than her white counterpart. And these things are not right.
It's evident that Dr. Idara has, in a very creative way and in her own way, has been solving the problem of maternal mortality. And I will summarize that you are doing that by being an advocate of proactive care. Now, proactive care is something that you've used to set the foundation of Birthsafe from the story that you've shared with us today, and it's so inspiring to see what you're doing. And it's very much connected with what we'll be talking about today. We're talking about self-advocacy. This is a very important topic to everyone, whether you're already looking to have a child or even if you've already given birth. And as a woman, generally, this is very important for all of us, whether you are in Nigeria or even beyond the shores of Nigeria. Birthsafe is impacting life within Nigeria and outside of Nigeria. This tells us that even Black women in diaspora, they need information, because without information, you cannot advocate for yourself. So this topic is about self-advocacy, how you can advocate for yourself during pregnancy, during childbirth, and more broadly in women's health. So Dr. Idara, why do you think self-advocacy is important? And you've mentioned that maternal mortality is the leading cause of death for women in Nigeria and even globally. Why do you think advocating for oneself is very important in this scenario?
Thank you. We have seen over time that when women, when the woman herself is informed, especially on critical aspects in pregnancy and childbirth, she gets better care. She gets better quality of care. So the interaction that she has with her caregiver is different. When a woman knows, for example, what her hypertension, what normal hypertension, blood pressure numbers are, she knows what normal PCV numbers are, she relates differently to the caregiver, and the provider, the health provider, sort of sits up a little bit because they know that this is not someone whose eyes you can pull the wool over. And so she comes and she says, okay, I am experiencing, compare these two conversations. Hi, midwife or doctor. I am experiencing abdominal pain. I know that, yes, some types of pain are common and expected in pregnancy, but mine is lower abdominal and it feels like a period pain, and I am aware that this type of pain is associated with threatened miscarriage or pregnancy loss. That is a different conversation from my tummy is paining me. My tummy is paining me, it could be gastritis. My tummy is paining me, it could be anything. But when the first woman comes and she has that conversation with you, immediately your mind is thinking. So you know that you are poised mentally to offer her better quality care because you see that this is someone that knows what she's talking about. I'm keeping it brief and concise.
Yeah, so information, as you said, is very key. How are you giving women access to information through your platform, and how do you think people can take advantage of this?
Okay, so one of the core things that we do in Birthsafe is antenatal training, and our training program covers trimesters that are typically underserved and overlooked in pregnancy. For a lot of women, antenatal care begins around 13 to 16 weeks. This is when the first trimester would have been over. Unfortunately, the first trimester is the period where a lot of things can and do happen to take a pregnancy out. Especially for us Black women who are more prone to pregnancy loss than our white counterparts, this is not a sector, this is not a part of pregnancy that should be overlooked. Unfortunately, as it is overlooked. The fourth trimester also, this is when a woman has given birth and she's expected to go home with her baby. Of course, she's not attending classes to cover the fourth trimester. She's not getting information to cover the fourth trimester. So for a lot of women, management of fourth trimester is from friends, family, support forums, just gathering as much information as they can. In this fourth trimester, you can have postpartum sepsis, you can have postpartum hemorrhage, you can have hypertensive issues, especially again for Black women. And one of the benefits of having served so many women, thousands of women, is that we see patterns. We see patterns emerge. And so we see patterns of very, very young women in their 20s, early 20s, mid-20s, who had normal blood pressures in their pregnancy. They give birth, boom, postpartum high blood pressure. So now postpartum hypertension. So now it doesn't surprise us anymore because we are already waiting for it. And we keep telling them, and that's one of the things we tell them, the fact that you had high normal blood pressure in pregnancy does not mean that you should lose guard when you've given birth. So we now have a system for them, and we tell them this is how much you should check your blood pressure, and these are the numbers that you should look out for so that you're not surprised and God forbid you run into a complication such as stroke, cerebrovascular accident, because you did not know that this kind of thing could happen in fourth trimester. So that's what our antenatal training program does. It covers the entire journey of pregnancy and childbirth end to end, and it highlights gaps and areas that they should be on the lookout for so that they don't run into trouble.
No, it's very powerful what you said, Dr. Idara, about Black women being more prone to miscarriage. I think the statistics is about 40% more. And that's not just a data point. That's someone's mother, that's someone's sister, that's someone's daughter. So what do you think maternal health outcome looks like today for Black women, and why do you think the pictures matter?
So I'm going to use 3 countries. In the US, about 50 women in 100 are likely to die as a result of complications in pregnancy and childbirth. Most of them will be Black. In the UK, it is lower. It's been hovering around 13 for some time now. In Nigeria, it just recently dropped from 93 to 460. So Nigeria currently contributes about 14% to the entire global number of women who pass away in pregnancy and child. But there's something that I like to talk about when I'm on forums such as these. We always talk about maternal mortality. Little, if any, attention is paid to maternal morbidity. There are women who have been so traumatized mentally, physiologically in childbirth, they are alive, and because they're still alive, they are not counted as part of the maternal mortality statistics, but they are damaged. So they are coming out with stroke. That is not a win for me. They are coming out blind. That is not a win for me. They are coming out deaf. That is not a win for me. The mandate of Birthsafe is that no woman and no baby should exit pregnancy with any form of damage. You should not be damaged and your life should not be lost. There is no point. I saw one very, very touching case of a lady, again, a black woman in the US or in the UK, whose limbs had to be amputated and lower limbs as a result of complications in pregnancy and childbirth. That is not a win for me. Is she alive? She's alive. So she's not going to factor into the maternal mortality statistics. You say, oh, this one did not lose her life. But that's not a win for me, because no woman should have her body damaged because she went in for pregnancy and childbirth. So, yes, these are the things that we see and we try to address in the program.
Honestly, now I think we should talk about the healthcare system. As you rightly said, whether in Nigeria, in the UK, in the US, we know that the narrative is very similar, very unfunded, congested healthcare system. So we really like to understand what that actually means. And Hikmat will be covering this segment. Hikmat, is there anything you want to add to that background on healthcare system and why it is very important that we discuss this when as it relates to women in pregnancy and in labor as well?
Yeah, so it's a very important topic, and I'm glad that you're one of the very few people that is taking the bull by the horn, because currently a lot of people are on social media and you have taken the initiative to go through that route to get maternity care to people's doorsteps, which is a very kind and sincere thing to do, because to be informed, it means you have power. Yeah. The power to know, to ask what is wrong with me, advocate for yourself, and that is very important. So the social media thing is a very, very good initiative and a good place to start from, and hopefully it gets to many more people. Now, with regards to the racial bias happening in the maternal care system, where do you think that kind of issue comes from? Do you think that it comes from a place of socioeconomic status, or because our bodies are just more complicated than white people? And why has the healthcare professionals not done enough to tackle that issue?
Okay, so the reasons are multifaceted. That's the truth. They are multifaceted reasons. Okay. For example, Black people, and this is not just Black women, Black people are more at risk, are more likely to develop hypertension than non-Black people for genetic reasons. So I'll use just one example. There's this enzyme creatine kinase, which is present in more amounts in our skeletal tissues, our skeletal muscles, than our non-Black counterparts. So things like this are the reasons why a Black person is more predisposed to developing high blood pressure than a non-Black person. And in pregnancy, what that means is that a Black woman is more predisposed to preeclampsia. Now, there's a socio-economic factor. If the purchasing power of a Black woman is not as high as that of her non-Black counterpart, it is almost inevitable that more care will gravitate to the race that has a higher socio-economic status and a higher purchasing power. That's one. Two, in certain climes, the number of doctors that are trained to understand the peculiar conditions of Black women in pregnancy, they are not so much. So if you went to an average doctor in Africa and told them that you were looking for treatment for Kawasaki syndrome, you may struggle a bit, because that is something that you expect to see in Asia. Is not very common in Africa. It's the same reason someone would develop malaria in a temperate country, and it's almost a national emergency. They are calling the troops. They are calling everybody. Meanwhile, if you have malaria in Nigeria, it's okay, piece of pie. Anybody on the street can treat you. So it has to do with the kind of training that they're exposed to, the kind of training that they narrow down in. They are not narrowing down on matters that affect Black women, because they are not thinking, a white person is not thinking, I'm going to spend the rest of my career treating Black women. A white person is thinking, I'm going to spend the rest of my career predominantly treating white people. So when they see a Black person and unique Black conditions, fibroids and pregnancy, PPH, they are not thinking to be proactive about PPH. They're not thinking to be proactive about preeclampsia, because a white person could have 130/90 millimeters mercury blood pressure and It just stays the same throughout pregnancy. For a black woman, that's the warning sign. You're already thinking placenta abortion. You're thinking intrauterine growth restriction. You're thinking so many things. You're looking for the protein in your urine. The bells are going off in her head. Pam, pam, pam. But for a white person, you're like, what's the big deal? And so this is why white women or black women come out of those sessions. They feel unheard. They feel unseen. This thing is a red flag. It may erupt and it may snowball and erupt into something that either takes me out or takes the pregnancy out. But the white doctor is like, I've been seeing so many white women with this. It doesn't amount to anything. It's just a little thing. It's not little for her. But there is a disconnect. There's a discordance because he or she does not understand. That's not what they were trained on. That's not what they are used to. So there's the socio-economic aspect. There is the genetic component, and there's also the training. What kind of training were they exposed to? So these are just some of the factors.
That is quite unfortunate, to be honest. And one would think, the irony there is for Africa, we're predominantly black, so one would think that our healthcare would be tailored to our genetic makeup, or, you mentioned the skeletal compositions and why it makes us predisposed to this kind of illnesses. I feel like our continent entirely should be more tailored to what we're feeling, rather than just general medicine or speculations. It should be like tailored to us to give us the appropriate treatments.
I was speaking for black women receiving care in pregnancy in the diaspora.
Yeah.
In the diaspora. At home,
okay.
Yes, in Africa, it will be more along the lines of socioeconomic status, because I don't want to call names. I hate to call names, but a doctor attending to a Tenny or $10 is going to be more thorough with what they are doing than attending to something is malaria endemic. And people don't know how dangerous malaria in pregnancy can be. So I'm just going to take a couple of minutes to talk about it. Malaria in pregnancy can literally mop up a woman's blood. So a woman can literally go from 36% PCV to 24%, and nothing else happened apart from the fact that she had malaria. Because the placenta is such a juicy, warm, beautiful organ to this malaria parasite that they sequester there. In the placenta, I want you to visualize a bag of blood. That's the placenta. And so the malaria parasites go there and they are just multiplying and they are just grabbing and grabbing. Meanwhile, the placenta is supposed to deliver nutrients from the mother to the baby. And here we have the placenta that is chock full of malaria parasites. So these nutrients cannot even come from the mother to the baby. And so the baby is like, hello, where's my food? Where's my oxygen? Where's my blood? Where's my nutrients? It's not getting to the baby. So that baby keeps going smaller and smaller and smaller. The mother's body, the malaria parasites are consuming the mother's blood. So you see intrauterine growth restriction and you see major drops in PCV. That's one. Socioeconomic statuses. The women, a lot of times, they either do not know, and this is where information is key. They do not know that this is the danger of going in for childbirth with this degree of PCV. And so a lot of them, unfortunately, are told that 30% PCV is okay. We don't subscribe to that in Birthsafe because we like to give the women wiggle room. If you have 36% and you lose 2 bags of blood, you land in 30%, you're okay. If you have 30% and you lose 2 bags, there's a
Sorry, go ahead. No, I wanted to ask you a question, but maybe I'll just let you finish.
Go ahead.
So you've mentioned PCV like 5 times now. What does PCV mean?
Is the measure of blood in a person's body.
Yeah.
It's the measure of blood. It's the measure of the amount of blood. It's just a way of us referring to the amount of blood in a person's body. So for other places, like in the UK, sometimes they call it hematocrit, sometimes they prefer to use hemoglobin, but we like to say PCV. It's measured in percentages. So it's the amount of blood is a measure of the amount of blood in a person's body. Yeah.
So why is it so important? Why is it so important in pregnancy?
That's what I was just going to say. So a lot of healthcare providers, they don't impress on the women enough about how important it is in pregnancy and childbirth. Like the example I just explained to you. If the woman does not have sufficient blood, if you don't have enough blood, you are not going to be able to deliver through your placenta enough nutrients to your baby, and that could affect the growth of the baby. In fact, sometimes it could threaten a pregnancy because we've seen women who came in with threatened pregnancy loss. They were spotting in pregnancy, and just correction of the PCV was all that it took for the symptoms to stop. Same thing with intrauterine growth restriction as a result of low PCV, anemia in pregnancy. But I was telling you about insurance and proactive antenatal care. If a woman has 30% and you tell her that it is okay, if anything happens and she loses 3 bags of blood, she loses 2 bags of blood, she's landed in 24, she's landed in 21%, she's anemic. Now guess what? The lower the amount of blood in a person's body, the lower the amount of clotting factors, and the more likely they are to bleed. So a woman that has 45% PCV and a woman that has 30% PCV, they are not mates. This one that has 45%, she has more clotting factors, and so her bleeding can be arrested faster. This one that has 30% does not have quite as much, and so there's a higher chance of her just wah. These are the things that we shout and we scream about. If you have fibroids in pregnancy, it is double wahala, because I'm going to use my fist as an example. If there is nothing inside this fist, if this fist is a uterus, the uterus is expected to form a tight fist after birth. You see that? Nothing is passing through. It's expected to form a tight fist and clench those blood vessels so that they stop bleeding. If you have a cut on your finger and you apply pressure, after some time, what will happen? The bleeding will stop, right? It's the same thing in the uterus.
Yeah.
There are bleeding vessels where the placenta was detached from. If it is able to form a fist, puts pressure on those bleeding vessels, and eventually they stop. If you have fibroids, you have fibroids. Let me look for something. You have fibroids. Is it able to make a fist? So this is like a fibroid. Is it able to make a fist? It can't make a tight fist. So all this allowance, can you see that? Instead of doing this, this is what you see. And then it is pouring. And so what we say is, if you are planning to go for it, don't give us baseline 36%, build it to 40, because you are thinking that you might lose more blood. If you have fibroids in pregnancy, build it to 40. So this is the way that we use information to tailor and customize what they should be doing for themselves in pregnancy to avoid running into complications. It's really simple, it's really beautiful. Yeah, I like it.
But how does the woman build the PCV to the desired
we give
level?
them the protocol.
What are those things?
We give them the protocols to use. We give them the organic things to do. We tell them the medications that they can take. And for those of them that are not in Africa, we even tell them the equivalents that they can find. We give them a meal plan. We tell them how to eat so that it can be helped to build their blood. We don't just tell them build your PCV. We actually show them and give them the things that they're supposed to be doing.
Yeah.
I think when we add the diaspora layer, because many of our listeners are also like based in diaspora, we see that you are in a foreign country, they're trying to navigate their healthcare system, you don't have your families nearby, and you are just navigating the whole pregnancy on your own. And of course, everything you've said shows that with information like what you can get on Birthsafe, you are able to bridge that gap. But I feel there's still, a woman can try to get that information, but it's still important that the healthcare system is working in our favor, because if you have the information, you need them to listen to you so that they can advise you. How do you think women can advocate more proactively to get the healthcare system that is not generally already well built for us to work for us, and to ensure that women go into the labor and they come back safely with their babies?
Beautiful. So one of the ways that a woman can implement and execute the antenatal training she has received is in the hospital. When you go to the hospital, ask questions. We tell you what to ask in your first trimester, in your second trimester, in your third trimester. We tell you the questions. Ask questions. Don't be shy. You have a right to ask these questions. My baby is so and so and so. What kind of pain am I going to, pain relief am I going to receive? Are you going to allow me have pain relief? Are you going to keep uterotonics for me? Are you going to ask questions? Because we see that a lot of times when they don't ask questions, they don't get answers. They just go into for those antenatal visits and they hear everything is fine, everything is fine, everything is fine, everything is fine. See you in the next visit. And they still go back with their concerns. They go back, they feel they have unmet needs, unanswered questions. But if they can ask, if they can settle down, not in a challenging manner, not in a confrontational manner. Hello, midwife. Hello, doctor. This is what I'm seeing. This is what I'm feeling. Like, oh, really? I didn't know that. And the feedback that we get is that they get very They are surprised. Their healthcare providers are surprised. Oh, I didn't know that you knew this. Oh, I didn't know that you were interested in this. Which is what encourages us to tell more women, to inform and guide and train more women, and tell them, open your mouth in the hospital. Ask questions. I am spotting. This spotting is increasing in color. It should not be. It is bright red. It is associated with cramping. It is increasing in color. This is an ominous sign. This person knows that you know what you're talking about. Can I get medication? Can you check me if I need progesterone support? Can you check me if I need... It is different from saying, oh, I'm having tummy pain or I'm spotting. What should I do? So when you are trained, when you receive that training, go to the hospital and actually implement. I am seeing 2+ proteins. This urinalysis result and report you're showing me shows that I have 2+ proteins. And you told me that my BP is 130/80. I'm a woman of color. This is preeclampsia looking for my trouble. Can you start placing me on antihypertensives? That's a different conversation from what am I going to do? So generally, medical health service providers...
I really like what you said, Dr. Idara.
They are more diligent. It shouldn't be so, but unfortunately, that is what it is. They are more diligent and they are more proactive to women who appear to know what they are looking for and what they are doing and what the right things are in pregnancy and what the normal things are in pregnancy. So that's the power that education, that's the power that knowledge brings.
Yeah. No, self-advocacy is one thing. I like that you give examples of the methods of how to actually advocate for yourself. But what happens when you're not being heard? Because there are situations like that when you're not even being confrontational, right? You're telling them clearly from your informed perspective that, okay, I think I have this, I've been feeling like this and this and that. But most times, a lot of doctors won't even offer checks. They will tell you maybe it's stress, or they will generalize your symptoms and make you feel, it's a pregnancy symptom. So just rest it out and see. And then we've seen people's experience that because they were not listened to, even when they advocated for themselves, the situation has become more severe. And exactly because they were not listening, even though that they spoke out, they advocated for themselves. So what do people do? What do women do when they advocate for themselves and the healthcare professionals still don't listen and do the right thing?
Beautiful. So this is where the support system comes in. And we advocate a lot for the women carrying their partners along. Your husband, your partner, carry them along. I'm going to digress a little bit. There's what we call pregnancy brain. The memory area of the brain shrinks a little bit in pregnancy. So it is very normal for women to forget things. So a woman could say, okay, this is my plan when I go to the hospital. I'm going to ask A, B, C, D, E. She gets to the hospital, she forgets everything. If her partner has been carried along and she says, babe, my blood pressure has been rising. This has been the pattern. Babe, I've been spotted. Babe, this is what I need to do in pregnancy. This is the help that I should receive in this pregnancy. And she forgets. Her backup, her support system remembers. And so in the event that the hospital is not taking her seriously because they think, okay, this is a subjective thing, maybe you're exaggerating your symptoms, her support system can say, no, she's actually not exaggerating. She actually did spot yesterday. Her BP was 130 yesterday, and we would like a solution to this. This is where they say 2 good heads are better than 1. In the event that particular outfit, the facility is still not responsive, then they can either, or the particular person, either midwife or doctor they're speaking to is not responsive, they can seek a second opinion in that same facility or change the facility. So if a midwife does not seem to be attending to you properly, or a doctor is not attending, you can ask from the hospital, can I have another doctor attend to me? If the entire facility is not giving you what you want, then you can get care from another facility.
I really like what you said, Dr. Idara.
So summary, there's 3 layers. Get backup from your support system, get a second opinion within that facility, and then change the facility if need be.
Particularly in Nigeria, right? Nothing scares me currently, like me personally currently, than trying to have a baby in Nigeria because of my experiences. Not personally, but there are people that I know. Okay, right. You are one of the few people that have made changes, and that is really, really good. But I used to have this huge fear, considering that we speak of advocacy, we speak of being informed and all, but I feel like a lot of Black women and Nigerian women particularly have been bullied into silence. So you go to antenatal, you see the healthcare professional, the midwives, they are all like bossy and this, do this, oh do that, oh do this. don't come and complain to me. Oh, this one that you are vomiting, don't stain me. This one. So it doesn't give you that confidence to even voice out because it feels like you're complaining too much. They make you feel like you're too much, right? So I don't know why they've already worked on your psychology and it has already collapsed your confidence. So you're unable to even speak in those settings. And unfortunately, not everybody has the ability to maybe go to a private hospital, even though it's more expensive, but sometimes they tend to listen to you better, right? But a lot of people are not in that position, like economically, and they just settle for the government hospitals, what they can get. And that is where the masses go to, and that is where the bigger problems erupt from. So you're in labor, you're not allowed to scream, or you're screaming, somebody is telling you, oh, when you were doing it, was I there? So this kind of things, they're really, really funny. Like, I wouldn't want to be screaming and stuff like that, right? But then it's different in every other part of the country. You go there, even if you're screaming, somebody's telling you, you know what, you can do this, they're giving you encouraging words and stuff. And one would think that, you know, you're black too, you're Nigerian, you should be able to understand me better than, you know, when I'm not the pain. But then they will bully you into silence, that you end up, you know, going through traumatic experiences that you don't even want to give birth anymore. I'm never coming back here because of my experience. So those are one of the things that haunt me whenever I think about, would I even want to have a baby in Nigeria? But thanks to you, people like you that try to, you know, make people take people more seriously, you discuss the aspect. Because in social media these days, we see how people minimize pregnancy. It's a 50-50 thing. Somebody would go into labor and they're not even sure if they will come out alive, right? But then you see exactly. So people would be on social media and see maybe Temi or Tedola. That's like the recent
Is that not your mate?
Men are comparing.
Is that not your mate?
Exactly.
How can you tell me that pregnancy is making you do this?
Saying,
Is that not a woman like you?
Here, you cannot pound yam for me. If I say she pound yam for me, you cannot do exercise. You are here spitting. You are here doing that. But the care we're getting is not even adequate in the first place. So how are we even supposed to function like her when we don't even have people? Because there's one thing to have the equipment, there's another thing to have humanity. And I feel like even if the equipment and the medicines and everything, they're there, if the humanity is not there, then we're never going to move forward.
Yeah.
So I think you should actually drop something for healthcare professionals that are listening to this, encourage them to try to make them more human. Because
so we have programs that we do where we train nurses. We call it Train One to Reach Many, and we kicked off the first one in Lagos last year. It was such a blast. The nurses didn't want to go again. It was such a blast, and we are going to do more this year across different states in Nigeria. Once we've just tweaked one or two things in our app. So it's called Train One to Reach Many, and these are part of the things that we teach nurses about. We train nurses on. We train them on empathy. We upskill them. We tell them, okay, when you see this, don't dismiss it. It might be a red flag. When you see this, don't dismiss it. And the childbirth experience, as you have mentioned, is so important. You're not expected to scream at a woman and tell her, am I the one that gave you the pregnancy? It's wrong. It's not professional in any manner, shape or form. So yes, we do training for nurses as well. And secondly, a lot of people don't understand the power of community. We have seen so many women chatting in our various communities. They are chatting. They are 7 cm dilated. They are 8 cm dilated. It's paining me. It's paining me. What should I do? It's like, push. This nurse is not answering me. Tell your husband to call her. Tell your husband to call her. He said, hey. He said, yes. But I'm not feeling the contractions again. Get up. Oh, but the nurse is telling me to lie down. Go to the toilet. Go to the bathroom. So she'll go to the bathroom. Mama, he walked up. I'm feeling the contractions again. Honestly, when we created the training programs and then we created a community to provide that support, even I did not have an idea of just how useful that community would be to the fellow women, to the women themselves. They love it. So at any point in time where they are not sure if the treatment in the hospitals they are getting is the right one or is not the right, they even get hospital recommendations there in the community. I am here. Oh, this is where I live. Which hospital should I use? Use this particular hospital. Look for this doctor. This doctor will do. Do you understand? This doctor is very empathetic. Look for this nurse. Look for this. Oh, this is what they are telling me. Don't agree. It's not the right thing to do. They are ignoring you. So that's the power of community. So those are the two things that I agree with you on. These need to be empowered. I want to call it empowerment because a lot of them do these things because this is what they were raised in the profession to see. They don't know better. I also have to talk about the shortage, the staff shortage. NHS too is overwhelmed. and that's why the wait times are so long. There's a policy in NHS right now that for you to have proactive management of pregnancy loss, you need to have lost that pregnancy 3 times. It's hurting us more as Black women because we are the ones more at risk of pregnancy loss. And so I'm sure that is part of why we see so many women from the UK, because the second highest number of our users, they come from the UK. We had a case that almost moved everyone to tears. She had lost 5 pregnancies. She's in the UK, 5 pregnancies. She and her husband had gone everywhere. They went to the US, they went to the UK, everywhere. And they could not find the reason why till they came to Birthsafe. So she was not expecting, in her words, she was not expecting to get anything from Birthsafe because the money was just peanuts. She wasn't expecting to get anything. She was just saying, okay, let me just do it and fulfill all righteousness. Let God see that I've tried. And she came and she was going through the classes, she was going through the training, and she heard things that she had not been told before. And she said that day she was on her way to work and she was listening to one of the classes. She just called in and said, please, I need to go to the hospital. Did a U-turn and went to the hospital and said, hey, did you guys check for X, Y, Z? And did I think that this is the problem? She said, no. What do you mean? Kill me, and why do you think is the problem? Check this thing, do another profile, run everything again. And they ran it through and found out that she was low in a certain hormone. And they were like, oh my God, how did you know? She called her husband could not believe it. She said, you mean it took an antenatal program? You didn't even go to the hospital physically. It took an antenatal program in Africa to point out where the issue was coming from. They put her medication for that low hormonal issue, and her child will almost be 1 year today. These are the things that women in the UK, they go around and like, oh, you're having pregnancy loss, go to Birthsafe. Oh, you're struggling, go to Birthsafe. Birthsafe. But the point is, we are millions and millions and millions of Black women across the world, and conversations like this are important. As medical practitioners, we can do better. I know that not everybody has the gift of teaching. Not everybody has the gift of breaking things down, but at least we can show empathy. At least we can be considerate to patients when they come. At least we can listen to them and take their concerns seriously. Because as you, Balikis, and
Hikmat. Hikmat.
Unless I see your expressions of pain, unless your facial expressions show me that you're in pain, I cannot know that you're in pain. You have to tell me. You have to say to me, doctor, I am hurting. And I'll ask you, where are you hurting? Oh, I'm hurting you here. I'm hurting here. And then I'll ask you, what is the nature of the pain? You say, oh, it's like a burning sensation. I say, okay. Do you react to paracetamol? You say, yes, I had paracetamol. I didn't eat. I say, okay, it's ulcer. If you don't tell me, I will not know. It's the same thing in pregnancy. You cannot dismiss a woman's concern. I'm in pain, you say it's not. I feel this, you say it's nothing. You may not have the gift of teaching and breaking information down like this, but with a little bit of empathy and a little bit of time applied to a case to say, okay, let me just pay attention here. It may be something, it may be nothing, but it is better that it is nothing than it is something and I ignored it. If that mindset is what we adopt going forward, I really believe that we'll see a drop, we'll see a decline in not just maternal mortality, because it really irks my soul when we talk about maternal mortality. There are women in their houses who are paralyzed right now because they were pregnant. They are not counted as maternal mortality statistics. They matter. Their conditions matter. A woman who has gone blind in childbirth, she's not mentioned anywhere, but she matters because she has been damaged as a result of complications in pregnancy and childbirth. So she matters as well.
Yeah. Maternal mobility, that was what you called it earlier, Dr.
Mobility, yes.
So
mobility.
Mobility is very important.
Yes.
Sarah, what you were saying about the NHS being overwhelmed, the waiting list very long, that is the reality, right, for many of our listeners today, which we also see that many of them are joining from the UK anyway. And if what you were saying about having the information, using questions to implement those when you go to your antenatal clinic, and if you are not getting what you want, like Hikmat was saying, if your questions are being dismissed or your appointments are being rushed, and you just feel like maybe this clinic is not where I want to continue my antenatal care and where I want to have my child, what would you say should be like maybe top 3 or 5 things that a woman should put into consideration when thinking of an antenatal clinic to go to? Some people do not have a choice. They go to the closest antenatal clinic to them, and while others, maybe they can have one or two choices. What would you say is super critical for you to put into perspective when you are thinking of where to get your antenatal care in person?
In the UK or in Nigeria? Because those are 2 different scenarios. Nigeria.
Yeah,
In the UK,
in
Everywhere.
anywhere
I think
in
everywhere.
UK,
Yeah.
I believe there
it's
will be.
not a one size fits all. Okay, so maybe I will start with Nigeria and then I'll enter the UK. It's not a one size.
Okay, yeah,
Yeah. In Nigeria, you want to be sure that the basics are available. You always have a doctor on hand. You don't want to be in a facility where if anything goes wrong, they have to start calling the doctor and the doctor has to come from 10 miles away. So there has to be a doctor on ground.
Wow.
A doctor that can handle an obstetric emergency. So I'm thinking maybe CS. A doctor that can handle a cervical laceration. There has to be a doctor on ground that can handle a neonatal emergency. So a pediatric doctor, very important, a pediatrician. There has to be oxygen on ground. There has to be access to blood. These are things that can save your life. There has to be, we said 5, okay. There has to be an ambulance so that in the event that this facility cannot manage you, immediately you are moved to another facility. So that's Nigeria. In the UK, and the same way I'm going to say that the UK is overwhelmed, they have long wait times, I'm going to give it to the UK that their reactive care, when they actually establish that there's a problem, is very strong. And that is why, kudos to the NHS, that is why you see that the numbers, maternal mortality numbers in the UK are lower than for a country like the US. US is doing like 4 times the maternal mortality numbers of the UK. It makes no sense. But the reactive care is better. Where they still fall, where the UK still falls is proaction, that there's fire on the mountain and then all the guns come blazing out. Where the UK can sit up and improve and better these numbers, proactive care. So to your question, what should she look out for? This facility, have they managed women of color before? What is their management protocol of threatened pregnancy loss, threatened miscarriage? Do they tell you everything is fine, or do they actually give you interventions? Do they give you medications? Do they give you a note, if need be, that you should be on bed rest so that you don't have to go to work? Because these are some of the surrounding things. We call it auxiliary intervention. So a management protocol, a medical management protocol is typically consists of core things, core medical things, and then supporting things. One of the supporting things that is very critical around threatened pregnancy loss is bed rest. And you know how the UK is. The public transport system is very good. So a lot of women use the trains. A lot of women use the buses. The bus is not going to come to your house. You are going to walk to the bus. The train is not going to come to your house. You are going to walk to the train, most likely for work if the woman is working. So if that facility has enough empathy to be able to recognize that this issue, whether it's a subchorionic hematoma or a threatened miscarriage, can lead to pregnancy loss, and they are quick, they are willing and able to give her medication for it and to give her a note to her employer to say, this lady needs to be off work for so and so and so time. That is a good hospital to use. So are they familiar with dealing with things like fibroids, with things like preeclampsia, with things like threatened pregnancy loss? Are they willing to give medication on time? Are they willing to give a note to her employer to say she needs to be off work so that she does not move around and agitate the uterus into sending out the pregnancy? So those are some of the things I'll be considering if I had to be a pregnant woman looking for the best care in the UK.
Yeah, and so that means you need to do your research. You need to get the data.
You need to ask questions.
Be able to,
you need to do your research.
Like reviews as well, like women that have used
absolutely,
this as well.
Absolutely. What is your
and
attitude
Dr. Idara, when you mentioned, when you mentioned pregnancy loss and the story you shared about the woman experiencing the miscarriage 5 times before she was able to get help through Birthsafe. Now, as you rightly said, in the UK, if you have a miscarriage the first time, they just tell you it's normal. Almost every woman loses her first pregnancy.
Yeah.
How do you advocate for them to investigate why you miscarried, even when it has just happened the first time? How do you ensure you are not part of that statistics that it has to be up to 2 times, 3 times, 4 times before something actually happens? I've also read a story where the woman lost 4 times, and the only reason was because she was anemic, but they didn't pick this up. They didn't treat her. They didn't give her iron supplements, and she should have saved those pregnancies if they found out. And it happened here in the UK. So how do you push for them to do that investigation?
Honestly, because it is a policy thing. This is why these women are resorting to self-help, because it is a policy thing. Because the UK, the NHS has a policy that if you haven't lost a pregnancy 3 times, you are not qualified to be seen by, to be taken seriously by the pregnancy loss unit. And so this is why these women resort to self-help.
Yeah.
The other thing that they do is they try to have that conversation. They try to find humane practitioners that they can talk to and have a conversation with. This is my obstetric history. This is what I have been going through. Can we do this pregnancy differently? I don't want to lose this pregnancy again. At that point, it's 50-50 because you hear stories of, this one was particularly kind. This one was particularly considerate. When I explain the situation, I say, okay, I understand where you're coming from. Let's see what we can do further. Or let's see what we can do more. But again, you see that all that still stems from a place of the woman actually knowing what is going on. That's why she's able to have that conversation and say, see, it is because I did not receive progesterone support. It is because I did not receive hematinics. It is because I did not receive XYZ. PCV can cause pregnancy loss. High blood pressure can cause pregnancy loss. How can you support me better? I don't want to go through the trauma of losing another pregnancy. This is a stronger conversation than just saying, what are you going to do? I don't want to lose another pregnancy. You see the difference? She's coming with data. She's coming with knowledge. She's coming with stats. She's telling you, I know that this is a likely cause. I know that this is a likely cause. I know that this is a likely cause. This is what I experienced. I know that you can do something to help me. Just write out a prescription for me. Compared to, I'm tired of losing pregnancies. What are we going to do? What are we doing here? That's a different conversation. Yeah.
Thank you so much for answering that question. And around the world, there is a concept of birth plans, right? So with people that have that, what rights would you say most, or if not all, women have in those birth plans? What can they consent to? What can they reject? What can they opt for? That will be taken seriously.
About 3. Around birthing, around 3. 1, informed consent. Any birthing method that you want to implement on a woman, she has the right to accept or refuse. She has that right. So if you said to her, you're supposed to birth, you're supposed to have an instrumental delivery, you have to seek her consent. You're supposed to take her for CS, you're supposed to seek her consent. Blood transfusion, of course, you're supposed to seek her consent. Any medication, any intervention. So there's this procedure that we call external cephalic version, where a baby is presenting breech, and then manually on the surface, you try to turn so that the baby's head faces down. You have to tell the mother, this is what I want to do. This is the reason why I want to do it. These are the risks. These are the likely consequences that can occur from this procedure. So everything that you want to do to a woman and on a woman's body, you need to seek and obtain informed consent. Secondly, a woman has the right to refuse. She can say, I don't want to give birth via CS. She has refused. She has the right to refuse whatever medication and intervention you want to carry out on her. 3, she has the right to say, I want so and so person to be with me in my delivery suite. I want my husband to be with me. I want my doula to be with me. I want a birth partner supporting system to be with me in the delivery suite so that I can feel more comfortable and I can feel encouraged. So there are more, but these are the broad 3.
Thank you very much for answering that. That brings me to a very critical question and an experience that I have seen somewhere. So like around 3 months back, a video was circulating about a woman that actually needed CS to deliver her baby, but then the hospital was insisting that her husband has to consent to the CS. So is that something generally that every medical facility does, or what does that mean for women? Does it mean if your partner is not there to sign some documents, she can have CS?
I don't want to throw away my wig. I don't want to get so heated up that I throw away my wig. A woman is a full-fledged adult. I'm trying to pretend that I'm a respectable person here because there are some things that I hear. My hair will just stand. My whole hair will stand. In 2026, a woman is not an appendage of a man. She's not a man's body part that he has to consent and say, okay, I give you permission to go up and come down. Especially in a situation as delicate and as critical as pregnancy and life and childbirth, where 1 second can be the difference between life and death. It is archaic practice for a hospital to say it is your husband that will give consent. And frankly speaking, in such settings, is usually tied to economic power. When you see programs, when you see platforms like MasterCard Foundation, they keep pushing for women and youth to be financially empowered, especially in developing countries. There's a reason why. Because if you can pay for the procedure, a man does not need to sign for you. It is usually tied to the economic factor, because it is not about you signing. When they now say, okay, madam, the bill is 2 naira, you say, well, actually, do you understand? If a woman can pay, she can sign. A woman is an adult, she should be able to sign. Her support system should be able to sign. In the event that, okay, maybe something has happened and she's not able to speak for herself, her support system, her designated support system should be able to sign. It can be her mother, it can be her mother-in-law, her sister, her best friend. It must not always be the husband. So it is archaic practice for any hospital to insist that it is the husband that gives consent. A woman is an adult. She should be able to advocate for her life and say, take me to theater and remove this baby.
Thank you very much for that beautiful answer.
Yeah, Dr. Idara, earlier in the conversation, you also mentioned about fibroids being a very common condition, and there are many women today that might be listening, and maybe they have fibroid and they are pregnant, and it sort of complicates the whole pregnancy for them, moves them to high risk. What do you think we should be putting into perspective when we are having appointments with doctors and are pregnant with fibroid?
Number one, pain relief, pain management of fibroids. Pregnancy, typically, especially if the fibroids are up to medium size or above, pregnancy can typically agitate fibroids or be associated with a condition that we call red degeneration, where the fibroids grow so much that they outstrip their blood supply and they become painful. Pain management. A hospital that knows how to manage pain beautifully when a woman has fibroid in pregnancy, chef's kiss. That hospital will always have Birthsafe seal of approval, because it can be a nightmare. The pain of fibroid in pregnancy has led to so many hospital admissions. The pain is nothing that you want to know about. It can be that painful. So number one will be fibroids. Number two will be thinking ahead. If this woman has significant fibroids, like I explained to you, you expect that her uterus is not going to form a fist. So you already start thinking ahead that this woman might lose more blood than the woman who doesn't have fibroids. What are your plans for it? Have you kept uterotonics, fundal massage, all of that, the things that will help the uterus to constrict better? Number three, the hospital should also be thinking about prolonged labor because of uterine atony. Remember that the uterus has to generate uniform and beautiful contractions to send out that baby. And because they are fibroids, they hinder generation of beautiful uterine contractions. So the hospital should also have that in mind, and there should be continuous fetal monitoring to ensure that the baby is not in distress, and in the course of trying to labor and send the baby out, nothing happens to the baby and we lose the baby.
No, thank you, Dr. Idara. And I know fibroid is even like a more broader and deeper conversation, but you've covered it very beautifully and summarized it. And for those people that don't have fibroid, those women that don't have fibroid, what would you say there are two things that you should be doing to prevent or protect yourself from having fibroid, especially if you're a Black woman? And as you already said, Black women are more prone or at higher risk of having fibroid.
This is interesting because fibroids typically are genetic. There's a genetic component, there's a familial component. So the genes is the genes is the genes. If you have a family history of people that have fibroids you have a history of people who have fibroids in your family, you're likely going to get it. But the things that you can control, I mentioned it before. The first one, sugar. Exposure to a lot of sugar, and exposure to a lot of fat, especially saturated fat, the kind that is used to make junk food. So our meat pies and our donuts and our things like that. So the more fat cells that we have, the more estrogen is produced. And when estrogen is not pushed back on, so when you're pregnant, progesterone pushes back on estrogen and says, okay, give us a break. But when estrogen keeps going and going, then there's a tendency for those tumors to form and they grow bigger. Another thing would be age of pregnancy. Still is a modern day thing. More and more. Back then, women were getting pregnant 17 years, 18 years, 19 years. Now people want to go to school, they want to work, they want to be financially established before they give birth. If this is providing a longer runway for estrogen to keep on acting on those cells uninterrupted. Like I said, in pregnancy, progesterone pushes back against estrogen. But when a woman stays longer without getting pregnant and she's exposed to a lot of junk food, a lot of sugar, she has a genetic disposition, she has a family history of fibroids, is a master chef recipe for fibroids to happen.
Okay. Fantastic. Thank you so much, Dr. Idara. I'll say that with everything we've discussed today, if you were to paint a picture of this is what equitable maternity care should look like, what would that be?
Equitable maternity care, maternal health care, would be care that takes, I already said it, first trimester right down to fourth trimester into consideration. No trimester is more important than the other. Every trimester is important. Equitable maternal care would be care that addresses the concerns of Black women as significantly, as robustly as the care of white women are being addressed. Equitable maternal care would be care that allows the woman, that provides the woman every training and information that she knows. These women are not medical. They are not nurses. It is pregnancy they are carrying. They are not medical practitioners. A lot of these things are completely new to them. So care that provides women with as much information as possible, what to expect, what to know, what to learn, what to do, what to avoid in order to avoid complications in pregnancy and childbirth. Care that does not only take maternal mortality serious, but does everything to prevent maternal morbidity as well, because a damaged woman is not a win for maternal health outcomes. And then lastly, care that factors in her partner. A lot of men are not carried along. So care that carries along her partner better, how to support the woman in pregnancy. I think it will help us. So these are just the proactive. If you want to talk about maternal health, there's the proactive, there's the reactive. We've not talked about the reactive. This one is not reactive, because if you're talking reactive, then you have to talk about the number of personnel, you have to talk about infrastructure, you have to talk about having enough hospitals, you have to talk about having enough. So the reactive, this is assuming that the reactive and the infrastructure, they're robust and they're on ground. And then policies as well. So policies that are more humane, so to speak. The policy of, I know that the NHS is overwhelmed, but it is really traumatizing to expect a woman to have lost pregnancies 3 times before you take her concerns seriously. A lot of these women are broken by the time they get to that 4th pregnancy. A lot of them are really, really broken. They are anxious. In fact, we met with one who said that, what can we do to ensure that she does not conceive in a particular month? Because those were the months that she conceived and she lost her pregnancy. And the NHS told her there's nothing we can do. So that he knows you have to lose 3 pregnancies. And it's a lot. It's a lot mentally. Also, policies, adjustments that are more humane and are kinder, especially to women of color. That would be more equitable care. So if we could look at things like the response times, if a white woman calls that she's in distress in pregnancy and a Black woman calls that she's in distress in pregnancy, are they attended to? Do they receive attention, the same degree of attention, the same time, the same way? That would be equitable care.
Thank you, Dr. Idara. And you also said, as you've rightly mentioned, we've been focusing on proactive aspects of care, because that's what we know that many women have in their control. That's what you can do. The reactive one is beyond our control, the healthcare system, the personal etc. But when you were saying, you mentioned something, 4th trimester. Pardon my ignorance, but I don't know what 4th trimester is. What many people know, and what I know is there are 3 trimesters in pregnancy. So okay. So the 4th trimester is the postpartum. Why do you think postpartum is? Why do you think postpartum?
A lot of complications. So the 3 leading causes of maternal mortality: postpartum hemorrhage, hypertensive issues, and sepsis. Sepsis, we see it in 4th trimester. Postpartum hemorrhage, we can see primary postpartum hemorrhage during childbirth, secondary postpartum hemorrhage after childbirth, 4th trimester. Hypertensive issues, I've already said it. Hypertensive issues can present in pregnancy, they can present during childbirth. For a lot of women who have normal blood pressures in pregnancy, they are surprised that they see high blood pressures in 4th trimester. And so if you don't pay attention to that 4th trimester, we like to say that pregnancy, the journey of pregnancy and childbirth does not end when a woman has given birth, when the baby is out. No, you still have to monitor that woman to ensure that things go back to how they were before and she doesn't run into any issues that could take out her life. Because what have you gained if you delivered a woman of her baby successfully on Monday, Tuesday she runs into complications, she's gone? It's still maternal mortality. So that fourth trimester is very important. At least for the first 12 weeks, eagle eye. Are you okay? Are you all right? Eagle eye. Very important.
That's very good. Thank you so much for that answer. But I would also like to ask, as much as everybody knows that, in most hospitals, within 24 or 48 hours, women are discharged to go home, right? But then what are some things that you think a woman should look out for that she should automatically switch into action? Like, this is an emergency for me.
We just mentioned
this is not normal. So I think the question, what is not normal?
We just mentioned
in that postpartum.
So if her blood pressure is going up, we said it. If her blood pressure is going up, if she develops a fever, if her bleeding dramatically increases, especially if there's low abdominal pain, her bleeding increases dramatically in volume, those are things that she should look out for.
But
with blood pressure then
can
be quiet.
Exactly. And does that mean every woman should be checking her blood pressure when she gets home? She has just been discharged.
Because we always tell our women check. It doesn't take anything. 5 minutes once a day, just check your BP.
And they are accurate, you think? Those home kits, compared to...
They are very, very, in fact, they are life-saving. They are life-saving because it is unrealistic to expect a woman to be going to the hospital every day after she's given birth just because she wants to keep tracking her blood pressure. We will not be able to get compliant. They want to rest. Every woman who has given birth wants to rest. But if you tell her, just check at home, her husband can check, her support system can check. When she gets up in the morning, first thing, she just checks.
Okay. For people that are not medical professionals like you, what would you think should be the ranges, especially with that blood pressure? Because sometimes the symptoms might mask something. It does not come to everybody. So for some people that maybe get epidural during the childbirth, they might have headaches afterward, and they will just say, oh, it's a normal thing when you get the epidural sometimes to have headache postpartum, But then headache is also one of the symptoms of high blood pressure, right? So what are the ranges in, how would I say, the numbers on
anything over 130.
Check kit?
Anything over 130.
Anything over 130.
Yes, anything over 130 is high blood pressure. 121 to 129 means caution. Watch carefully. So you want your blood pressure, at least the systolic range, to be between 120 and not below 90. 120, not below 90. 121, 129, observe with caution. Keep checking it. Anything 130 and above is high.
Okay. So if I'm to understand you correctly, what women should be looking out for in postpartum would be fevers, the bleeding increasing instead of decreasing, headaches, and when the numbers are above the ranges that you just mentioned. So those are the common symptoms that they should look out for and call the hospital immediately if those come up. Thank you very much for that. That will be very helpful for our audience. Thank you.
Dr. Idara, honestly, I believe we've covered so much in this episode. And when I asked you the question about the picture perfect that you see for maternal health, you beautifully summarized everything that we've been saying in a nutshell, and also what women can do that is within their own control. So honestly, I think Birthsafe, what you're doing is very, very inspiring. You're changing the narrative and you're giving women the power to be able to take their own health in their own hands. So we like to understand more. What are those things you are working towards, especially for Black women in diaspora? What are the innovative solutions that we should be looking out for that will also work towards solving some of these problems that we've mentioned?
So already we are doing a lot on the training aspects, and we're coming out with our app that is going to incorporate tracking as well, so that some of these things, it's no longer take the lesson and go and implement. We can also do some of these things for them. So the app will also help to track certain parameters that are very dear to our hearts in Birthsafe, so that the women can see. And I like to use this example. I know almost everybody watched Titanic. Remember the movie Titanic? The Titanic song, not because it was a bad ship. The Titanic song because the people who were supposed to be watching out for danger were distracted by two lovers doing their thing. And by the time they saw the iceberg, in fact, I have no better summary or better analogy of how women run into danger. It was too late. That is in pregnancy and childbirth, because like I said, they are not doctors. You've said it. They are not doctors. They are not nurses. These are just normal everyday women who got pregnant, and they don't know a lot of this concept. So in addition to training them, we see that they can do better if we also sort of handhold them through an app that says, okay, this is day 21. You're supposed to do this. You're supposed to do that. You get up today and you do this. You check for this. Something like that. So we are going to be tracking them through the app, and to make sure that when we see ominous signs coming, they are aware, their support systems are aware. We escape, or what do we call it? We we take steps, or we carry out measures. Yes, measures are carried out. You have enough time to ward off the ominous signs and make sure that you don't run into trouble. So yes, so that's what the app is going to do. It's going to combine training, it's going to combine tracking, so that women have a more robust antenatal guidance experience.
Okay, so is the app live today, and can women outside of Nigeria have access to the app? Is the app live today?
It will soon be live. Women outside Nigeria will, of course, be able to have access to the app, and it will be available, of course, on Google and iOS. So yes, any woman at all, in fact, whether you're black, you're white, even though we are more tailored to matters that affect Black women, but any woman at all will be able to access the app. And the beauty of it as well is that for those who are underserved and those who are maybe struggling with economic issues, they can access it. It makes access easier because you can access it on a monthly basis. You can make payments on a monthly basis. And so for a household who is struggling with apportioning funds, it is easier to say, okay, it is not an either or. You can carry along a woman getting robust antenatal training because it is not too heavy on the pocket, taking into consideration the Nigerian reality, the African, the sub-Saharan reality. In the UK, it's not going to be up to £5 a month, so it's piece of cake, piece of pie. But for those in Africa, we are looking to see how we can encourage more people to have access so that they know exactly what they're doing. Because it will interest you to see how excited women are when they are told things that they should be doing in pregnancy. Oh, madam, what's your PCV? Why is your PCV 28%? No, your PCV should be 38%. Really? I didn't know. So I'm supposed to be taking this. Thank you, doctor. Thank you, doctor. Nobody told me. I will. This thing is not difficult. I keep saying it's not difficult. Once patients are informed, they are told the consequences of certain things, and they are told this is what you should do to avoid that consequence. There's nobody that wants to die. Nobody wants to die. Patients can be very compliant. Just tell them what they need to know, tell them what the consequences are, and watch them comply. It's a beautiful thing, really. So yes, that's we are looking forward to having that out by August, and then
fantastic. So it's going to be a paid app, and if you are to say today, for women listening to this episode and they are pregnant, they want to start using your services, they want to get all the knowledge and everything, how do they access Birthsafe Nigeria today?
Okay, so you can access the services on the website. Yes, you can access the services on the website, www.birthsafeng.com. You can go to the Instagram page. There's a link there. Once you click the link, it gives you direct access to the program. You get access to the community. There's a free complimentary consult. You have access to all the trainings and everything else that we do in the program. So you can either use the social media pages, which will be the IG page, or you use the website, which will be www.birthsafeng.com, and then you get access from there.
Okay, and all of those are also paid services, right? Or are they free? They are paid services. Yes, are they free or they are paid services? They are paid. Okay. No, that's very clear, because I know these are some questions that people will be having on their mind, and how do we get all of this knowledge? Because it's been very wonderful to hear everything that you do at Birthsafe and the amount of information that you can give to women and in their palm, right from their phone. They can get all of this information, and they are more informed when they go to their antenatal clinics. So it's been great having you with us, Dr. Idara. Thank you so much for your time. I don't know if Hikmat has any further questions or any closing words.
So thank you so much, Dr. Idara, for bringing maternity care to our doorsteps. Those are kind of the revolution that we need in every aspect of life. We need to bring important issues to people's doorsteps and watch people embrace it. just like you said, when you reach out to people and tell them that, okay, this is what actually, there's a lot of people that are receptive when they get people to talk to them about what is actually going on with them. And that's very important in the kind of content that we share on this platform. We talk about awareness. We bring people, experts like you, to also make it feel relative to people. Let them that, there are people out there like you that care about what they're going through and you're willing to bring solutions to them. So to the audience out there, you should watch out for this app that is coming up in August, and do well to patronize. And I think it will be more beneficial to even the audience than you, because of course, how much are you charging, right? If it concerns something as delicate as a life, saving a life is much more important, because some people are there with their money. Even with the money, they can't save the life, they can't preserve what they're trying to preserve. So it's a very beautiful thing that you're coming up with. So thank you very much for your initiative and being one of the most caring and humble person that I have ever come across. So thank you very much.
You're very welcome. Thank you for having me. Thank you so much.
Thank you, Dr. Idara. I don't know about you guys, but for me, I'm going to be a Birthsafe mama when that time comes, because honestly, we missed out on any of those information that will be very, very important in saving my life and the life of my beautiful one. So thank you so much again, Dr. Idara. I think we can end this session now.
Shared on this podcast are not to be considered medical advice. Always consult with a qualified medical professional for all your health concerns. Thank you.